Hey, welcome to The Explainer. Today we are diving deep into the pharmacology of ischemic heart disease. This one's for all you medical and pharmacology students out there. We're not just going to memorize drug lists. We're going to break down how these key drugs for angina actually work, right down to the molecular level.
All right, so here's our game plan. First, we'll nail down the core problem, that oxygen imbalance that's at the heart of IHD. Then, we'll walk through the three classic drug classes we use to fix it: nitrates, calcium channel blockers, and beta blockers, really focusing on what makes each one tick. And to wrap it all up, we'll zoom out and see how these all fit together in a complete treatment strategy.
So let's start with the why. Before we can even talk about the drugs, we have to get a solid grip on the actual problem they're designed to solve in ischemic heart disease. When you boil it all down, IHD is just a classic supply and demand problem. Your heart muscle, the myocardium, it's working hard and it's demanding a certain amount of oxygen, but the coronary arteries just can't supply enough to meet that demand. That mismatch, that oxygen debt, well, that's ischemia. And that's what causes the chest pain we call angina.
So here's the bottom line. Every single drug we're about to talk about has one simple goal: to fix this imbalance. They do it in one of two ways. They either decrease the heart's demand for oxygen by slowing it down or making it pump against less pressure, or they try to increase the oxygen supply. Just keep that simple scale in your head as we go through each class.
All right, let's jump into our first class of drugs, the organic nitrates. These are fascinating, they have a really cool history, and their mechanism is just beautifully direct.
Okay, so check out this pathway. Nitrates are actually prodrugs, which means they get converted in the body into their active form, which is nitric oxide, or NO. This little NO molecule then goes and flips the switch on an enzyme called guanylyl cyclase. That, in turn, cranks up the levels of something called cGMP. And the final crucial result? It causes the smooth muscle in your blood vessels to relax. And relaxed vessels mean wider vessels, vasodilation.
And get this for a piece of historical trivia. In what has to be one of the greatest ironies in medicine, Alfred Nobel, the guy who invented dynamite, was eventually prescribed its main ingredient, nitroglycerin, for his own heart problems. I mean, you can't make this stuff up. It's a pretty powerful testament to just how potent this compound is.
So in practice, we use different nitrates depending on what we're trying to do. If someone is having an acute angina attack right now, you need something that works fast. That's where sublingual nitroglycerin comes in. It works in just a minute or two. But for preventing attacks from happening in the first place, for prophylaxis, we'll go with a longer-acting oral pill, like isosorbide mononitrate.
Now, if you remember one thing about nitrates, let it be this. At normal doses, they are mostly venodilators. They relax the big veins. By doing that, less blood returns to the heart. We call that reducing preload. And think about it. A heart that isn't stretched out by a huge volume of blood doesn't have to work nearly as hard to pump. That drop in workload is what lowers the oxygen demand.
Okay, next up, another group of vasodilators, the calcium channel blockers. They get to a similar endpoint, wider blood vessels, but they take a completely different road to get there.
The core idea here is really simple. For a muscle to contract, calcium has to get into the cell. And in the smooth muscle of your blood vessels, the main doorway for that calcium is the L-type calcium channel. Well, calcium channel blockers, or CCBs, do exactly what their name says. They go and stand in that doorway, they block the channel, no calcium gets in, and the muscle just relaxes. The vessel dilates. Simple as that.
Okay, pay attention here, because this is a huge point, both for exams and for real-life practice. You have to know the difference between the two main types of CCBs. You've got the dihydropyridines, like nifedipine and amlodipine. Think of them as vascular specialists. They mostly work on the blood vessels. Then you have the non-dihydropyridines, like verapamil and diltiazem. They're less picky. They work on the blood vessels, but they also have major effects directly on the heart, slowing it down and weakening its contraction.
So if we said nitrates are all about reducing preload, then CCBs are your go-to for reducing afterload. By dilating the arteries, they lower the total resistance that the heart has to pump against. It's like trying to push water through a fire hose instead of a garden hose. It's just easier. And when the heart's job is easier, its demand for oxygen goes way down.
All right, time to switch gears completely. Let's talk about our third major drug class, the beta blockers. These guys take a totally different approach than the vasodilators, and they're an absolute cornerstone for treating chronic stable angina.
And this is a really critical distinction. Beta blockers don't really care about the blood vessels. Instead, they go straight to the source, the heart itself. Their entire job is to just tell the heart, hey, take it easy, slow down, don't work so hard, especially when you're exercising or stressed out.
So how do they do it? Well, they block the beta-1 receptors in the heart. Think of it like they're putting earmuffs on the heart, so it can't hear the stress signals from adrenaline. This gives you 3 key benefits. The heart rate slows down, the force of each contraction goes down, and blood pressure drops. All 3 of those things dramatically slash the heart's oxygen needs, which is exactly why they're so good at preventing angina that gets triggered by exertion.
You'll notice that the beta blockers we use most often for IHD are cardioselective. All that means is that they're much better at targeting the beta-1 receptors in the heart. And that's important because it helps us avoid side effects. We don't want to block beta-2 receptors in the lungs, for example, because that could cause big problems for a patient who also has asthma.
Okay, so we've looked at the 3 big players. Now let's pull back and see the whole picture, because managing coronary artery disease is about way more than just stopping chest pain.
And real quick, it's good to know about some of the newer players on the scene. You've got drugs like ranolazine, which has a really unique mechanism involving sodium currents to help the heart relax. And then there's ivabradine, which is super specific. Its only job is to slow the heart rate down by targeting the heart's pacemaker, and it doesn't affect anything else.
Now this slide right here puts it all into perspective. The drugs we just spent all this time on, the nitrates, CCBs, and beta blockers, they're mostly for making the patient feel better. They're for symptom control. The real life-saving, foundational therapy for every patient with coronary artery disease are things like antiplatelets to prevent clots and statins to stabilize plaque and lower mortality. The anti-anginals are then added right on top of that essential foundation.
And that brings us to our final thought, a clinical question to tie this all together. Because understanding how these drugs work, their actual mechanism, isn't just some academic exercise for an exam, it is the absolute key to picking the right drug for the right patient, avoiding problems, and building a treatment plan that actually works.